In this final installment of the Deep Neck Infections lecture, we will complete our discussion of the potential complications of these infections. Another potential complication of deep space infections is vascular compromise. Vascular compromise can be divided into arterial and venous. And of the two, the more interesting is venous, actually. When deep space infection affects a vein in the neck, it usually invokes thrombophlebitis. That is, the vein becomes completely thrombosed and also infected. What this means is that embolic infected thrombus can break off from that vein and travel centrally. The next capillary bed that it will encounter is the capillary bed of the lungs. So if these embolic thrombi lodge in the lungs and form abscesses in the lung parenchyma, that is called Lemire syndrome. People frequently use the term Lemire syndrome to refer to the thrombophlebitis itself, but it's not really Lemire syndrome until you have parenchymal abscesses in the lungs. Arterial complications are thankfully rare and tend to be self-limited and tend to occur in children. Here's a patient with a deep space infection in the right neck. You can see thickening of the platysma muscle, you can see infiltration of all the fat planes, and this used to be the internal jugular vein. Unlike its counterpart, it's got no contrast in it. In fact, it is lower density than we would expect of the internal jugular vein, and that is thrombus within the vein. You can see enhancement of the wall, but no enhancement centrally. That's characteristic of thrombophlebitis. So far, all we have is an internal jugular thrombophlebitis, but it is worth checking the lungs now because here in the lungs, this patient also has abscesses, right? These are hematogenously spread lung abscesses, and there's the indication that we truly have Lemire syndrome, which is thrombophlebitis with embolic lung abscesses. Of course, also extensive infection throughout the lung parenchyma and pleural space. Here's another example of how thrombophlebitis may be seen on axial images. This is a patient who has a thrombophlebitis again in the right internal jugular vein, and you can see that the wall of the vein is much brighter than the central contents, and that's characteristic of an acute thrombophlebitis in this patient with an extensive neck infection. This case is included to show the arterial complications that may happen from a deep space infection. This is a peritonsillar abscess that has become very extensive and extended all the way to the carotid space, the neurovascular space, out laterally. This internal carotid artery is much smaller than its counterpart, and that is because of muscular spasm due to the surrounding infection. This occurs predominantly in children, and thankfully it is self-limited. Once the infection is taken care of, this artery will bounce back to its normal size, and it is very rare to get strokes or other further arterial complications, thankfully. I suppose for the purpose of completeness, it is worth noting that airway compromise is an emergency, and if the airway is narrowed, then you should call and speak to a referring physician. It turns out that the upper airway can take quite a bit of narrowing before it completely collapses down, but if you are at all concerned about the caliber of the airway, that is always worth a conversation. So another complication. Here's an example of chronic osteomyelitis. There is extensive erosion of the bone itself. There is erosion both of the cortical bone and the underlying medullary bone. And there are areas of either spared cortex or hyperdense material centrally that represents the sequestration itself. In this case, there is no periosteal reaction, although that is also characteristic. Here's an example that shows the periosteal reaction to better effect. You can see this ghost-like extra bit of bone along the lingual surface of the mandibular angle. That is a periosteal reaction. This appearance is referred to as Codman's triangle, and it is indicative of osteomyelitis. In this case, we can see that it is the offending tooth is this impacted wisdom tooth with an apical abscess that has cortical breakthrough. Well, it didn't just break through the cortex, it also broke into the medullary cavity to cause osteomyelitis. Our next potential complication is septic arthritis. The joint that we're often talking about in the head and neck is the temporomandibular joint. The imaging findings we're looking for are erosion of the cortex, cortical loss. We expect the joint to become enlarged, which is an unusual finding. In degenerative disease, the joint space shrinks. And there's surrounding inflammation of the soft tissues, as you would expect. Here is an example of septic arthritis as seen on CT. The upper cortical margin of the mandibular condyle is gone. This dense white line should continue all the way around the top of the condyle, all the way around the condylar head. But it is eroded away on the superior condyle. The thickness of the joint space is increased. These are findings of septic arthritis. The MRI in the same patient is on the next slide. Here's the MRI in that patient. You can see, once again, that the cortical margin, this black line now, should go all the way across the top of the condylar head. It's interrupted. There's abnormal enhancement all through the condylar head and neck. There's abnormal enhancement all through the surrounding soft tissues, particularly within the joint itself. And there's even inflammation within the temporal bone itself, within the glenoid fossa. And if you look carefully, you can even see there's a little reactive dura. That doesn't necessarily indicate intracranial spread of infection. It may just be sympathetic reaction of the dura. So this is septic arthritis of the temporomandibular joint. Earlier, we referred to suppurative adenitis as a potential source of infection, but it's also a potential complication of infection. This occurs almost exclusively in the pediatric age group. The retropharyngeal nodes are the most frequently involved nodes, and this is when an abscess forms within an overwhelmed lymph node. This is the classic appearance on the lateral plain film in a baby. We would like to see the prevertebral soft tissues above the level of the esophageal verge be less than half a vertebral body's thick, and below the level of the esophageal verge less than one vertebral body thick. This is clearly increased thickness of the prevertebral soft tissues, and that gets a patient sent to CT, hopefully with someone who can immediately control the airway if necessary. Here's the CT scan in that same patient. You can see that there is an enlarged lymph node in the retropharyngeal space. This is the classic location for a retropharyngeal node, but this one has become an abscess. It has a thick enhancing rim. It has very dark color centrally, and there is surrounding inflammation in the soft tissues. So suppurative adenitis as a response, as a complication to infection elsewhere in the neck. Our next potential complication is necrotizing fasciitis. You can think of necrotizing fasciitis as an infection that has gotten completely out of control. You usually see skin thickening, you usually see thickening of the platysma muscle far more extensively than the ones that we have been seeing previously, and you get diffuse fat stranding, meaning all through the neck. Maybe little areas of sparing, but all through the neck. The key finding here is the multispatial nature of the disease. If you see extensive edema throughout the paraspinal muscles and extensive edema throughout the superficial fat, then you should really start thinking about necrotizing fasciitis. It's the extent of the disease, the aggressiveness of the disease that allows us to suggest this diagnosis radiologically. Here's an example of a patient. You can see that in addition to the inflammation of the superficial fat planes and the platysma muscle, it completely fills out and thickens the sternocleidomastoid muscle, but it doesn't stop there. It continues through all of the deep fat planes. It continues into the prevertebral space, through the prevertebral fascia, into the paravertebral spaces. We just talked earlier about how this fascia, the prevertebral fascia, is an extremely good barrier to infection, but necrotizing fasciitis can overcome that and become an extensive diffuse infection. We alluded earlier to sinusitis as a complication of infections in the teeth. Let's talk about that in more detail. If you have an apical abscess of one of the posterior maxillary teeth, sometimes that apical abscess will erode through the overlying bone and extend into the sinus itself, into the maxillary antrum or maxillary sinus. This can occur in the setting of trauma, but usually occurs without any prior trauma, just as a result of the extent of infection. Here's an example. This is one of the molar teeth, the second or third molar. There is a large apical abscess, but in this case, the overlying bone is not just expanded and remodeled, it's eroded through, and the infection can stream on into the maxillary antrum. This is a frequently overlooked source of sinusitis. They aren't always this obvious. And often the radiologist will be met by resistance from dentists who would prefer that this not be the source of the sinusitis. But these patients undergo multiple sinus surgeries in an attempt to correct the recurrent infections. Until this tooth comes out, this patient will have sinusitis. So it is incumbent on us to firmly insist that this sinusitis is odontogenic in origin so that the patient can be relieved of their symptoms. In summary, there are 4 things that should be included on every dictation of a deep space neck infection. We should discuss the presence or absence of abscess so that we can decide whether the patient will be treated medically or surgically. We should define the extent of disease. We should look for one of the many complications that we've just discussed. And importantly, we should identify the source of infection, because until that source is eliminated, the patient will continue to have symptoms.